Thank you for joining us. My name is Audrey Hassan, Patient Liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Gamida Cell, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Louis Silverman, Associate Professor of Medicine in Hematology and Medical Oncology and Hematology Specialist at Mount Sinai in New York City. He is one of the foremost researchers in myelodysplastic syndromes, and he was the principal investigator for the clinical trials which led to FDA approval of azacitidine. The treatment of azacitidine that he has helped pioneer has changed the face of treatment for MDS. It has improved the outcomes for tens of thousands of patients and their families around the globe. Based on his studies, azacitidine has become the standard of care for patients with higher risk MDS and represents an important treatment option for older patients with acute myeloid leukemia. He is currently studying new therapeutic approaches to MDS, including the development of novel agents. The approach he pioneered demonstrated that epigenetic therapy, one that can reprogram cells, could be clinically effective in MDS and some forms of AML. Cell reprogramming is now being tested in other diseases to modulate gene expression and cellular behavior. He has conducted a variety of clinical and translational trials in patients with MDS and investigates different approaches given the nature and heterogeneity of the disease. The results of some of his studies provides leads which will help enhance treatments for MDS in the future. He also contributes to leadership in other research groups, serving as a member of the board of directors of the Alliance for Clinical Trials in Oncology, and serves as a member of the MDS Foundation Medical and Scientific Advisory Board. As the director of the Translational Research Center at Mount Sinai, he is bringing in new investigators to work collaboratively to develop new strategies to overcome the challenges in the treatment of MDS and to help find a cure for this most challenging disease. With that said, it is my pleasure to introduce Dr. Silverman.
It's a pleasure to be here today to talk with you on behalf of the MDS Foundation and talk to you about transfusion dependence and transfusion support in patients with the myelodysplastic syndrome. These are my disclosures. I receive research report support from a number of pharmaceutical companies and other sources to support our research here at Mount Sinai. MDS is a disease that has been around for well over 100 years described. So we certainly know a lot about it. And we're continuing to learn new things every year, make advances in our knowledge and advances in our therapy. However, we're still not nearly as advanced with respect to therapy as we would like to be. And so MDS research is a road that's well traveled, and it is yielding better results for patients than it did many years ago. So the myelodysplastic syndrome is a disorder that derives from a immature progenitor cell in the bone marrow. The average age of individuals with MDS ranges from 65 to 75 years old, and the dominant clinical feature is that of bone marrow failure. And the majority of patients who have the disease often get into difficulty with bleeding and infection. And although about a third of patients transform to a leukemic phase of the disease, the majority of patients get into significant difficulty still with marrow failure from bleeding and infection. The cause of MDS in the majority of individuals that have it is still unknown. We know that the incidence of MDS increases as patients age, that certain medical therapies given for other treatments, as treatments for other cancers, such as chemotherapy and radiation therapy, can lead to the development of MDS in patients. And there are certain environmental exposures, and benzene and petrochemicals are the best known that lead to MDS. There's been descriptions in the past about the role of tobacco that's not established. And there are other disorders such as aplastic anemia and certain hereditary diseases that lead to MDS that I'm not going to spend much time on in today's discussion. As I mentioned, MDS is an age-related disease, and here you can see the incidence. So although the incidence increases with age and concentrates in people in their 70s and 80s, you can see that there are people even in their 20s, 30s, and 40s who develop MDS and have the same form of the disease as that of older individuals. Now, blood is composed of a number of different elements. Blood, when we take it and put it in a tube, we can spin it down and we can see the elements that comprise blood. So at least half of the blood is comprised of plasma, which is a liquid form that forms from water, proteins, nutrients, and hormones. There is the so-called buffy coat, which is a thin layer that contains the white cell component. So you see the white cells do not make up a majority of cells in the blood. And then about 40 to 50% of blood in the normal individuals is comprised of red cells. So red cells constitute a significant portion of blood and give it its color. Now, blood is formed in the bone marrow. The blood cells are formed in the bone marrow. And the bone marrow is an organ, just like the heart, just like the lungs. And it is responsible for replacement of cells that have limited lifespans, lasting in the blood from a few weeks to a few months. And then they have to be replaced. And when there is stress on the system, if somebody has bleeding or an infection, then the marrow has to increase its output to compensate to replace these cells that are used up more quickly. So the bone marrow is a well-honed organ that strikes to keep the number of cells in the blood in balance and to keep it on an even keel. So if the blood production from the bone marrow diminishes for whatever reason, then the number of cells in the blood will diminish and you end up having lower blood counts because of impaired bone marrow function. Now, all blood cells begin as hematopoietic stem cells in the bone marrow. And here you see that hematopoietic stem cells lead to formation of more maturing cells until they become the end cells that are circulating in the blood. And this comprises white blood cells, various categories of white blood cells, platelets, and red cells, as well as parts of the immune system and predominantly lymphocytes, which are B and T lymphocytes. And you can see here that in patients that develop abnormalities of the hematopoietic stem cell, this can be abnormalities either within the cell itself or within the microenvironment of the marrow that nurtures the cells as they mature, then this can translate into abnormalities of the blood cell progeny, and you get stem cells that lead to abnormalities of blood cells as they develop, which develops into ultimately into low blood counts because these cells no longer mature or develop properly. And then you have low blood counts because the marrow is no longer producing adequate amounts of cells that get into the peripheral blood. The red cells are similar in that they derive from primitive stem cells that go through a maturational phase until they reach the red cells, which are the cells that we see circulating in the bloodstream. Now, for MDS, there are abnormalities that can develop at different stages of maturation. Most of the abnormalities develop in early immature progenitor cells. And in some patients with MDS, these immature progenitor cells or blast cells can mature incorrectly and accumulate in the bone marrow, leading to increases in the immature cells in the bone marrow. The cells, as they mature, often are defective and therefore don't mature properly and undergo a form of cell death where these cells die in the bone marrow before they ever leave the marrow, the so-called phenomenon of apoptosis. And because the production is diminished and ineffective, the number of cells that get out into the bloodstream are diminished, including white cells, platelets, and red cells. And we call this peripheral blood cytopenias in patients that have low blood counts. And there are a number of factors that go into controlling the production of blood, and therefore a number of factors that can be involved with abnormalities of the way blood develops. And blood cells in the peripheral blood have a variety of functions. So red cells are responsible for carrying oxygen primarily, and they do this as cells without a nucleus. So the cells have little capacity to deal with stress, and they have no renewal function, as opposed to white cells, which have a nucleus that can direct the cells. More specifically, red cells have a group of enzymes and proteins in their cells that guide the cells with respect to their function, which is primarily carrying oxygen. But because they don't have a nucleus, they have a very limited lifespan. White cells are involved in an immune function, attacking, evading organisms such as bacteria and viruses. And platelets are responsible for clotting. So if someone cuts themselves, then platelets, along with some of the proteins in the blood, are responsible for sealing off that area so the bleeding stops. Now, to establish a diagnosis of MDS, we do a series of tests on patients. The key among them is bone marrow, a bone marrow aspirate, and a bone marrow biopsy. Are really required to examine and look at the marrow, look at the cells in the marrow, and also, along with looking at the marrow under the microscope, we do a variety of studies looking at the cells themselves, looking at the proteins on the cells, categorizing the populations of cells that are in the bone marrow. We perform a test called cytogenetics, which is looking at the structures that house the chromosomes and the genes in the cell. And we can do other tests such as molecular tests and to ascertain abnormalities and the normalcy or abnormalcy of some of the structures that are in the cell. And this just gives you a flavor of what some of the cells in the marrow look like. These are white cells. These are normal, maturing white cells that we can see in the marrow and the blood. And in patients with myelodysplastic syndrome, the white cells are often dysplastic. And here you can see these are dysplastic white cells. And you can see the difference in the way the cells look under the microscope. Here, there's a well-formed nucleus. Here, the nucleus is abnormal. There are fewer granules here, and the cells have developed in a very abnormal fashion, leading to abnormalities of the quantity and of their function as well. So there are major abnormalities in patients with MDS. Now, MDS is a unique disease, but has features that sometimes can be confused with other diseases, and MDS has to be also distinguished from other diseases such as aplastic anemia, acute leukemia, myeloproliferative disorders, an entity called large granulocytic leukemia, which is an abnormality of T cells, and not so much a true leukemia, but abnormalities of T cells. And here at Mount Sinai, this is a particular interest of ours because we note that there are abnormalities of T cells in about 30 to 40% of patients with MDS. So it's very important to distinguish MDS from other diseases and to ascertain and ensure that the appropriate diagnosis is established. More recently, in the last few years, we've identified that there are a number of mutations in the blood and bone marrow of patients that have been identified that are involved with a variety of pathways that are critical to the functioning of cells in MDS patients. And the presence or absence of these mutations help us establish, one, the diagnosis of MDS, help us with determining and assessing the severity of the disease, and also provides some targets now for new drugs that are being developed, such as the presence of an IDH1 or an IDH2 mutation or an SF3B1 mutation that may help us select drugs for an individual patient and thus individualized therapies for patients. Now, there are other factors that are at play in patients with MDS that contribute to the disease formation. Epigenetics is an area that I've been interested in for a number of years, and we developed here at Mount Sinai the first epigenetic therapy using azacitidine, which is an epigenetic modulating drug that was the first drug approved for patients with MDS. Now, epigenetics involves proteins that regulate how genes are expressed. So one analogy to think about is that when you go to a concert, all of the members of the orchestra have notes on their books that contain the piece that they're going to play, and it gives them the notes that they have to hit with their instruments to play the piece that orchestra is focused on. That would be like the gene structure, the genes themselves, but the conductor helps the orchestra, the various members of the orchestra, with the tempo, with the timing, and the intensity, and the manner in which the notes are played on their instruments. And that is analogous to the epigenetic mechanism. It's the epigenetic regulator that really governs the tempo and expression of the information that's in the genes. So, and there are abnormalities of the epigenetic system that also lead to the development of MDS in patients. So this is another element that's very important in the disease itself. And more recently, we've also noted that MDS can develop in patients who have single, isolated low blood counts that may persist for many years. And when we look at the genomics of these patients, we can see that there are abnormalities in the gene structure, in some cases, a limited number of cells, which can expand over time and lead to the development of dysregulation of the bone marrow and develop into a full-blown form of MDS. So we call this, in its early phases, clonal hematopoiesis of indeterminate potential, or CHIP. And so this is something also that a number of us have been interested in, and we have many patients here in our institution that we follow with CHIP, monitoring them for development of further problems, and thinking about ways how we may intervene in the early phases of the problem to rectify it and correct the abnormalities in the bone marrow. So we're now developing strategies that we may be able to apply to specific patients to try to eradicate or reprogram the cells that have these CHIP abnormalities. Now, when we've gathered all of our information, we classify patients, and here you see is the International Prognostic Scoring System that was revised a few years ago. It's based on the cytogenetics, the bone marrow blasts, and the bone marrow function is gauged by the production of red cells, platelets, and neutrophils. And we break patients into a variety of categories ranging from very good to very poor. And the value of this is predicting how the disease is going to behave. So patients with very low risk disease have relatively stable courses that may be stable for many years before patients may develop worsening MDS. But patients with very high risk categories of disease have disease that tends to be more stable and requires therapies sooner rather than later. For patients who develop a red cell transfusion requirement, we note this and note that this is associated with a disease state of MDS that is less stable and leads to more problems for patients. And over the long term, patients who have a need for red cell transfusions don't fare as well as patients who are red cell transfusion independent. And this is true for both patients with good risk disease and patients with more of an intermediate category, and even patients with higher risk disease who have higher needs for red cell transfusions have disease courses that are more unstable and more fraught with problems than patients with lower red cell transfusion requirements. So with respect to MDS, the first critical element is to establish a diagnosis, which requires examination of the blood and bone marrow, looking at mutation profile, eliminating other confounding problems, to see whether there might be dysregulation of T cells or other problems that may be contributing to the low blood counts, and determining and predicting how the disease is going to behave. Hematologists are particularly expert at this, although in the US, oncologists are often equally skilled at managing patients. Patients can be referred to MDS centers of excellence, where there's a particular expertise in the disease, and there are foundations that provide information and support for patients. Well, what are our goals of care with individual patients for lower risk disease? And this is determined on a number of variables in the blood and bone marrow. Our major objectives are to relieve symptoms, to improve the quality of life, to eliminate the need for red cell transfusions, and to try and reduce the risk of the disease progressing and getting worse, stabilization of the disease. For patients with higher risk disease, again, based on similar parameters, our major objectives, in addition to symptom relief, is to improve survival for patients, to reduce the risk or eliminate the risk of transformation to acute leukemia, and again, to improve quality of life and eliminate transfusions. Now, the majority of patients with MDS have anemia when they present, and a large proportion of patients have red cell transfusions, have a need for red cell transfusions. Now, this is variable across lower risk and higher risk disease patients, but in patients with higher risk disease, the majority will be red cell transfusion dependent, and the same is also true of patients with lower risk disease who have a full-blown disease state. So what does anemia produce, and what consequences does it have for an individual who's severely anemic and requiring red cell transfusions? Well, patients appear pale, they may be cold, they may have shortness of breath when their hemoglobin levels are lower, particularly on exercise, walking up hills, climbing stairs. Their blood pressure may be lower. There are cardiovascular effects. Patients often have a rapid heartbeat. When the hemoglobin is particularly lower, particularly in patients who may have some element of underlying heart disease, they may have chest pain, angina. In some instances, it may precipitate an actual heart attack, although this is unusual. The spleen may be enlarged, and patients often complain of feeling fatigued, dizzy, or feeling that they live in a fog from their anemia. Now, iron is a key element for production of red cells, and iron is a key element in the body. And when in your normal diet, people take in iron through their normal diet in vegetables, in meat, fish, poultry. It's processed and it circulates when it's absorbed in the bloodstream and is deposited in the liver, which is one of the storage organs, and is also utilized in the bone marrow to make red cells. And it's also important in muscle for muscle activity. So there's a balance in the body of iron. Iron is absorbed from the intestine from nutrition. There can be spontaneous loss in the GI tract. As cells get renewed in the GI tract, there's an ongoing small loss, which is replaced through from dietary sources. There is transfusional iron for patients who have low blood counts when we transfuse them. And in patients who receive a lot of transfusional iron, we use a treatment called chelation that tries to remove excess iron. So in patients who are anemic or who are getting transfusions, there are considerations that we factor into managing the overall iron levels in an individual patient. So in patients, in the human body, there is no physiologic mechanism for the elimination of excess iron. So in patients who are heavily transfusion dependent for red cells, iron can build up in the system, and too much iron can lead to problems with end organ dysfunction if the iron burden becomes excessive. And iron can promote problems in patients over time, but there's still a lot of debate about how much iron represents too much iron. When should one intervene to consider trying to remove excess amounts of iron? But if iron is managed appropriately, then people can live with transfusions for very long periods of time. Now, with each transfused unit of red cells, there's a certain amount of iron that goes into the system. And that iron stays in the system when those red cells are used up. The body's very efficient about keeping the iron that's in those red cells and recycling it. So if you're not making appropriate amounts of red cells, then iron builds up in the system in an excess. And again, there are varying degrees of estimates in terms of what is the appropriate amount of iron buildup to be concerned about, to think about initiating treatment to remove some of the excess iron. And so there are some that say between 30 and 50 units of red cells is one measure, one metric. There are others that look at some of the parameters with respect to ferritin levels in the blood, which is a protein that binds iron in the bloodstream. And we can measure ferritin, and as iron builds up, ferritin levels can increase. So it's a rough estimate of the amount of iron in the system. But iron is not the only factor that pertains and governs reflecting iron stores. There are other factors that can raise ferritin levels to excesses that are independent of iron. So ferritin is not always a completely accurate reflection of iron buildup. And when iron does build up in patients, it can affect some specific organs that can lead to problems for patients down the road. So in particular, the organs we are most concerned about are pancreas, liver, and heart. So too much iron in the heart can lead to some weakening of the heart. Too much iron in the liver over a long period of time can lead to some scarring of the liver. And too much iron in the pancreas over a long period of time can lead to the development of diabetes and requirements for treatments for diabetes. But we have ways of managing iron buildup in patients, and we're selective about which patients that we ought to initiate therapy and which are the best candidates for chelation therapy. And chelation simply means that we use a drug that will bind a metal, in this case iron, and form a complex that then gets removed by the body, and so therefore the chelating agent is removed, and therefore the iron that's bound to it is removed. And so this is an effective way of removing excess iron from the body. And there are patients with other diseases other than MDS that have a buildup of iron, such as patients with hemochromatosis. And with appropriate management, patients with hemochromatosis, which leads to a buildup of iron in the body over a lifetime, those patients can be effectively managed, and they can live normal lifespans with the effective management of iron buildup. So it is feasible and possible to do. Now, ferritin is one method I mentioned. We can sample with a liver biopsy the amount of iron in the liver. We use non-invasive tests these days, so in addition to ferritin, we can do an MRI of the heart or the liver to help evaluate how much iron may be in those organs and help us assess the iron buildup over time. Now, as I mentioned, we assess individual patients with MDS for iron buildup over time and iron overload, but we also make assessments as to which patients are candidates for iron chelation therapy and iron management and who requires it. Some patients with MDS don't require it. So we look at the transfusion status of patients, we look at the serum ferritin. Our focus with chelation and concerns for iron management really focus on patients with lower risk disease who may have much longer periods of time where they're supported with transfusions measured in many years, where management of iron buildup is important. Also, we consider the long-term behavior of the disease, the stability of the disease, and which patients may be moving towards stem cell transplant, and do we need to consider iron management prior to stem cell transplant. So there are a number of ways that we can remove iron, and these are the three agents that are currently available. Deferoxamine is a drug that's been around for many years. It's given subcutaneously, intravenously to remove iron, can do it extremely effectively. There are agents. Deferoxamine is an agent that's available in pill form. It can remove iron effectively as well. However, one of its problems is affecting some of the blood counts. So in patients with very low platelet counts, this agent can be a problem, and we need to monitor it closely. And then deferoxamine is another agent that is taken orally and also can remove iron effectively, but also may affect blood counts, so that has to be monitored closely. So in patients who need many transfusions, we can manage the iron buildup, and we can help prevent iron toxicity in patients that develops over a period of many years. Patients who have high need for transfusions for a year or two still are not going to develop iron toxicity in their body and not going to impact their organs. Although iron buildup is important, one has to keep front and center the fact that the MDS is the culprit. It is the reason people need red cell transfusions. And treating the MDS, ameliorating the MDS, reversing the bone marrow failure, stabilizing the disease, improving marrow function, and preventing the disease from getting worse are really the key elements that we focus on with respect to treating patients. And if those treatments are effective, then the marrow function improves and the need for red cell transfusions diminishes significantly, and therefore the iron buildup problem goes away. So I want to spend the last few minutes focused on the treatment strategies that we use and what their impact will be on the need for red cell transfusion. Here you see just a list of some of the agents that I'm going to review briefly with you that are either approved and in use or being evaluated as potential new agents that can be effective in improving and the efficacy of treatment for patients with MDS. So in general, broadly, we break patients into higher risk and lower risk categories of the disease based on the IPSS-R that I talked about earlier. For patients with lower risk disease, our therapies are directed at quality of life, symptom relief, and reducing transfusion need. And I'll go through some of these treatments shortly. For patients with higher risk disease, our focus is on stabilizing disease, getting a response, improving for the survival for patients, in addition to improving quality of life, reducing symptoms. And hypomethylating agents form the first line of therapy for these individual patients. And for patients who we consider to be good candidates, stem cell transplant is a consideration, but that is an important discussion to have, but has its own issues that really are going to go beyond the scope of the lecture that I'm going to cover with you today. So for patients with lower risk disease, we break patients into a variety of categories. So we look at the serum erythropoietin. This is the red cell hormone. That's a normal hormone in people. It tells the bone marrow when to produce red cells. If the red cell hormone level, the EPO level is low, and the need for red cell transfusions is low, then we're likely to start with erythropoietin, a red cell hormone drug that is a form of the red cell hormone that people make. We give this to patients, and it can drive the marrow to make more red cells. If patients don't respond to erythropoietin, or they have a deletion 5q, then patients may move on to get treatment with a drug called lenalidomide that's particularly effective in patients with deletion 5q. If they don't have a deletion 5q, then they may get lenalidomide or azacitidine, and if they have a particular subcategory of disease that I'll talk about shortly, they may get the new drug luspatercept. If the serum erythropoietin level is higher, then we may use luspatercept earlier. We may use immune modulatory treatments, and we still may consider erythropoietin or lenalidomide or azacitidine, depending on particular elements of the disease in an individual patient. So we do try to individualize therapy for patients. So erythropoietin, again, for patients who have lower red cell transfusion need and low erythropoietin levels, the response rate can be upwards of about 75%. For patients who have some intermediate form of that, maybe a little bit greater red cell transfusion need or a little higher erythropoietin level, the efficacy drops off. For patients whose level of erythropoietin is high, particularly over 500, or if the transfusion need is great, more than 4 units a month, the likelihood of responding is very small. And you're going to hear in the community when you speak to others about risks that are associated with erythropoietin-based therapies. Because in other types of cancer, patients may get thrombotic events, meaning blood clots. There may be impact on survival and tumor. But this is non-MDS related. In MDS, none of these events have been shown to be problematic for patients receiving erythropoietin-based therapies. And erythropoietin is approved for the use by the FDA as a safe treatment strategy for patients with MDS. And with respect to red cell transfusions, you can see a risk profile here. I can tell you we transfuse patients all the time. The risk of viral and bacterial infections really is remote. Patients, if they have significant cardiac problems, we're cautious and we manage them so that heart failure is not a problem. Transfusion reactions are infrequent, and iron low overload we've discussed. But the benefits of red cell transfusions, at least in the first 6 to 12 months of patients with MDS, from their diagnosis and requiring red cell transfusions, leads to improvement in fatigue. But these effects over the long term are not durable. So with respect to lenalidomide, a number of trials have been done. And here you can see that this summarizes some of the trials. So lenalidomide in patients with a deletion 5q yields a response rate up to about 75% of patients responding to lenalidomide with rises in their red count and loss of transfusion requirement. In patients who do not have a deletion 5q, the response rate is lower, and I'll show you one particular study where there only about 20 to 25% of patients will respond. And whereas the duration of response in patients with deletion 5q to lenalidomide can be very long, measured in several years, in patients who don't have the deletion 5q chromosomal abnormality, the median duration of response is about 10 months. In this study, this looked at different doses of lenalidomide, a lower dose and the standard dose, the 10 milligrams. The responses were comparable, but when we looked at the chromosome responses, we saw better responses at the standard dose than at the lower dose. So I still favor the starting dose of 10 milligrams per day. In this study, this looked at 10 milligrams, the standard dose, versus just supportive care, placebo in patients who had lower risk MDS who did not have a deletion 5q. And the response rate here was 26% in the lenalidomide arm versus only 2.5% in the supportive care arm. And patients, and this is at 2 months from start of therapy, and a good percentage of patients were still responding out beyond 6 months, and the median duration of response in this study was about 8 to 9 months. So in patients who don't have a deletion 5q, the responses are not very durable, and after about a year, most patients have resumed transfusion dependency. Now, luspatercept is a new drug that was just approved last year. This is based on the fact that in the bone marrow of patients with MDS, that there is an increased protein that is produced that suppresses red cell maturation in MDS. And luspatercept blocks this protein and allows more normal maturation of red cell production. So luspatercept is just a protein that takes a piece of one protein fused to another protein, turns it into a drug that targets this abnormal protein SMAD2/3, blocks its effect, and lifts the suppression of red cell production in the bone marrow. This is a trial that was conducted, a phase 3 trial. The results were presented a little over a year ago. Patients were treated either with luspatercept or a placebo, an inactive drug. And here you see the results. So 38% of the patients treated with luspatercept became red cell transfusion independent compared to only 13% in the best supporter or in the placebo arm. Now, what was interesting here with this were patients with lower risk disease with very specific criteria. They either had ring sideroblasts in the bone marrow or they had a mutation of a SF3B1 gene. So this is targeted therapy requiring patients to have either ring sideroblasts or an SF3B1 mutation in order to benefit. Now, there are other mutations that are similar to SF3B1 that may benefit from treatment with luspatercept, but we're only developing data about that now. And so those are not mutations that are yet approved for the use of luspatercept in those patients with those mutations. Overall, about 50% of patients had some form of red cell response to luspatercept. And you can see the pattern is variable. There are patients here who get red cell transfusions and then lose their transfusions. There are some that have a resumption of transfusion and then lose it again while the drug continues. And then this is in the placebo arm where the transfusions did not abate and continued. So you can see that the transfusion requirement really does diminish in patients treated with luspatercept. So this was approved and is an effective form of treatment for patients with lower risk disease. And here you just see that the median duration overall for response to luspatercept is about 1.5 years, where patients benefit and then they lose their benefit at that time. It's well tolerated. It's given as an injection every 3 weeks, and patients tolerate the treatment quite well. Now, azacitidine, as I mentioned, was the first drug approved by the FDA. Its use today is primarily and it serves as the backbone for treatment of patients with higher risk disease, but it has a utility in patients with lower risk disease as well. This is as I mentioned, is an epigenetic drug that seeks to reprogram the cells and improve the function of the marrow, which it does effectively in about 50% of patients. And patients can have improvements in their red count, white count, and platelet count. It also prevents or delays the development of leukemia and improves survival for patients with higher risk disease. Now, this shows you that azacitidine reduces or eliminates the need for red cell transfusions in 50 to 60% of the patients in this particular study, which included patients with lower risk disease and higher risk disease. And the effect is prominent in patients with lower risk disease as well. And CC486 is an oral form of azacitidine. So although the main drug is given as an injection, CC486 is a drug that was just approved last year for patients with leukemia in preventing a relapse of patients from their leukemia. The oral azacitidine was tested in patients with lower risk disease, and it was shown that people could have transfusion independence. And here you can see a study that was just published last month. This is a phase 3 study of oral azacitidine compared to best supportive care. And the number of people, the median duration of transfusion independence was 11 months compared to only 5 months in the placebo group. So this was an effective treatment for patients with lower risk disease and reducing their transfusion need. Unfortunately, CC486 is not approved in the US or anywhere right now for patients with MDS who have a transfusion need. And how that will change in the future remains to be seen. Last few slides. There's another drug now that's being tested that's not yet approved called imetelstat. This is a telomerase inhibitor. Telomeres are proteins at the end of chromosomes that are important for maintaining survival of cancer cells. Imetelstat inhibits this protein formation, so it interferes with survival of the MDS cells, and it's being studied now compared to a placebo in patients with lower risk MDS. This is an active trial, actively looking for patients, and you can see here that about 42% of patients in a small study became transfusion independent, and it was these data that led to this larger trial. And the purpose of the trial is to determine the transfusion independence rate for red cell transfusions in patients with lower risk disease. The drug is well tolerated, and we hope that this study will be completed this year in terms of accrual, and that we'll get some readout on the results next year. The last drug I'm going to discuss is a drug called magrolimab. This is an interesting drug that's in active clinical trials. We have it available and are testing both the imetelstat and magrolimab at Mount Sinai. This is a protein that binds to a protein on the surface of MDS cells. On the surface of the MDS cells, this protein blocks the body's immune cells from attacking the MDS cells and removing them and killing them. This protein binds the SIRC alpha protein on the MDS cells and allows the macrophages and immune cells in the patient's body to thus attack the MDS cells and kill these cells. So that there are several trials that are ongoing, and this is just results from an earlier stage trial. Here you can see that 92% of MDS patients responded to a combination of azacitidine and magrolimab with a 50% complete response rate. And importantly, you can see that 44% of patients became transfusion independent for red cell transfusions. And this was predominantly in higher risk patients, some of whom had highly unstable disease and some of whom were previously treated. So we're also now looking at patients in lower risk disease categories to treat with magrolimab, and looking to see how magrolimab, either alone or combined with azacitidine, impacts the lower risk disease and transfusion dependency. Also in patients with MDS who have a particular chromosome abnormality, chromosome abnormalities and a G mutation called TP53, the combination of azacitidine and magrolimab have shown significant benefit, and this is this particular subgroup of patients will be part of additional studies with magrolimab. So there are certainly agents that are effective in producing responses and reducing transfusion need in patients with MDS. And there are a variety of agents that are undergoing clinical evaluation in clinical trials as new agents, hoping that these agents will be effective and join the group of drugs that are already approved to be effective strategies and treatments for MDS patients to improve responses, reduce transfusion need, reduce symptoms, improve quality of life, and overall positively impact the behavior of the MDS and improve the outcome for patients with this disease. And I want to thank you for your attention. And I want to encourage patients to consider clinical trials because as we learn more, this will help everybody to help develop better therapies for MDS. And I'm happy to take any questions that you may have at this time. And thank you for your attention. Thank you. hypomethylating agent could be effective. And depending on how long she's been transfusion dependent, one's going to have to consider chelation therapy for her. With chelation therapy, with a lack of other cytopenias, if her disease remains stable, she could continue to have reasonable quality of life with chelation therapy to help manage her iron buildup. So those are the various options. Stem cell transplant, if she doesn't have a donor, cord blood, cord units could be considered as an alternative for her as well, or even haplo mismatched donors might be a consideration. They're being done now more frequently in patients with MDS, and this, I think, also would be a consideration.
Thank you, Dr. Silverman. The next question comes from Gerald. Can lenalidomide be used in combination therapy with luspatercept?
That combination hasn't been tried yet. Certainly, there's some rationale for combining luspatercept with other drugs, but there's little or no data about combining luspatercept with other drugs as yet. There are some trials that are in the planning stage or on the startup stage, but there's no data on a combination of lenalidomide and luspatercept to date.
Thank you. Jacqueline wants to know, how is response to treatment with platelet transfusion dependent patients for an elderly 81-year-old?
So platelet transfusions are given for older individuals or for anybody who's severely thrombocytopenic and at risk for increased bleeding. If you're in a patient who's severely thrombocytopenic, really it depends on whether it's the MDS, whether there might be T cell component that is contributing to the thrombocytopenia. Some patients with MDS have immune thrombocytopenia or ITP. Now, this is a relatively common disease in patients who don't have MDS. It's an autoimmune disease. It's associated with certain other autoimmune diseases. And we see an autoimmune component even in MDS patients. So therapies with IVIG and steroids can be a consideration for these patients, might be helpful. We've used thrombopoietic agents. They carry some concern about destabilizing the disease, but if monitored appropriately, can be used successfully in MDS patients. The mainstay for patients with thrombocytopenia really often is hypomethylating-based therapy. So patients with severe thrombocytopenia, even if they're lower risk, can respond to treatments with either azacitidine or decitabine. And the oral form of decitabine is approved in COVID for patients as an alternative to intravenous decitabine. There's less data about efficacy of Inqovi in thrombocytopenic patients at this point. But I would say that there certainly are therapies available to consider for patients, and 81 is not too old to be treated. We treat patients routinely in their 80s and even well into their 90s with treatments, and they tolerate the treatments just as well as younger patients.
Great answer. Thank you. Miles is a patient who's being treated with luspatercept, and the drug had an effect over 12 to 18 months. He wants to know what happens after that time. Is there a more rapid progression of the MDS, a sudden increase in the need for transfusions, or does the patient simply return to their status before luspatercept treatment?
Most often, the patients will return to the status of their disease state prior to starting luspatercept. And on the information I have provided, the median is about 1.5 years. So this seems to be about on target for what's been demonstrated with the treatment thus far. But there's kind of a resumption of transfusion requirement without the disease progressing to a different level. I mean, certainly disease over time gets worse. That's the natural history of MDS, and the treatments can intervene and change that. Survival, the effect of luspatercept on survival was not studied in this trial, and so we don't have any data as to whether patients benefit with respect to survival, but it should just return back to its state prior to starting luspatercept.
Thank you. The next question is, can iron be removed from the blood prior to transfusion?
Some physicians give desferoxamine, which can be given as an injection under the skin, infused under the skin, or given intravenously. Some physicians give desferoxamine intravenously either prior to or after transfusions. It's not as an effective strategy as giving prolonged chelation therapy, which removes more iron. So it can be utilized to remove some degree of iron, but it's just when it's given as a quick infusion, it's just not as effective as prolonged infusions. And so logistically, we favor a subcutaneous infusion over 8 to 12 hours, several days a week to chelate the iron, or to use the oral formulations to chelate iron.
Thank you. Madeline wants to know if you can talk a bit about patients' quality of life when receiving weekly transfusions and what can be done to help them.
So that's an important question. We did a study a number of years ago in the Cancer and Leukemia Group B, and my nurses really helped run that study and were instrumental in conducting it, along with Alice Kornblith, who was at Memorial at the time. We did a quality of life study looking at patients who had MDS, lower risk and higher risk, the majority of whom had red cell transfusions. What we found in that study was that a patient's quality of life can be benefited from getting transfusions. Their symptoms diminish, they feel better, they feel more energetic. But the quality of life benefit from transfusions is limited in terms of time. And what we found is that the transfusions effect dissipates after 6 to 12 months in the average patient. And after that time, the red count goes up, the hemoglobin goes up, but the symptom relief diminishes, and the symptom relief often is lost after a period of time with just red cell transfusions alone. Thus, it's important to use other therapies to try to render patients independent of transfusion need and to help with symptom relief. So transfusions are an important support measure for MDS patients, but their effects are not endless in terms of improving quality of life. But some of the therapies that we administer, even though they may have side effects, we demonstrated in our studies that they can improve quality of life significantly for patients while improving the blood counts and improving the state of the disease. So by diminishing the MDS in the marrow, this often turns into improvement in quality of life for patients. So treatment really is the key to improving quality of life.
Thank you. The next question is from Jacqueline. She has intermediate risk unclassified MDS, has had one cycle of Enclovi, and was recently hospitalized with a neutropenic fever. I think she may be asking, it wasn't in question form, but is this common or related to Enclovi?
So the Enclovi can lower the blood counts. Enclovi is an oral formulation of decitabine. Decitabine and azacitidine can lower the blood counts initially in patients. So Enclovi can do the same. Patients are supported through either with preventative antibiotics or white cell boosters to help support their white count during the low period after the Inqovi treatment. They're monitored closely. What we showed with azacitidine is that even though the azacitidine may lower the white count in the initial month or two from beginning treatment, that the greatest risk for MDS patients comes from the MDS itself. And that despite the fact that the drugs may lower the white count transiently, that the majority of patients have their increase in risk of infection from the MDS. And we did this by comparing patients who were getting treatment versus patients who were just getting supportive care. And what we found was that despite the lowering of the white count transiently in patients getting treatment, it was actually the patients who were getting just supportive care in our comparative phase 3 trials who had the highest risk of infection and bleeding. And so thus the disease itself is the culprit in causing the bleeding and infection risk. So for somebody who's had one cycle of Inqovi and had neutropenia, fever is not that uncommon. We use preventative antibiotics to try to tide people through, and white cell booster support. They can be managed, and with continued therapy, the disease can respond and the neutropenic periods can reduce or go away, and patients can fare better. So I think physicians caring for patients in that setting just need to have that kind of discussion and encourage patients to continue therapy and make it as safe as possible.
Thank you, Dr. Silverman. Maureen wants to know if there are any therapies that reduce the need for platelet transfusions.
So, yes, there are. For patients who have, first of all, thrombocytopenia with platelet transfusions is going to be more common in higher risk patients. And the therapies for our higher risk patients are based on hypomethylating agents. Azacitidine is still the standard of choice, either by itself or combined with other agents such as venetoclax, magrolimab, and other particular agents. And patients who respond can have increases in their platelet count to the point where they no longer require platelet transfusion support, and often can have normalization of their platelet counts as a consequence of treatment. In some instances, patients may start out with platelet counts that don't require transfusions, but may end up needing transfusions as they start their therapies and go through the first 2 or 3 months. But that can abate as the marrow improves and the blood counts improve and transfusions can diminish and the requirement can abate.
Thank you. The next question comes from Newt. Can you provide information on CAR T therapy in MDS?
So far, there's very little that's been done with CAR T in MDS. There are some trials that are ongoing. The problem has been identifying a protein on MDS cells that is not shared in common with other cells in the bone marrow. CAR Ts right now have been predominantly focused on patients with acute lymphoblastic leukemia, ALL, certain types of lymphomas predominantly, and other types of lymphoid or lymphocytic-based diseases. And the reason is that there are some antigens that the T cells, so the CAR Ts are, one takes patients' T cells, reprograms them so that they are then re-injected into a patient so that they can attack a particular target. So on the B lymphocytes, there are particular targets that can be utilized to eliminate not just the cancer cells, but many other normal B cells. But people can survive well without those B cells in their body. in myeloid cells, which produce white cells, the platelets, the red cells. If we target those stem cells, then the marrow function diminishes and may not return. And that's been the challenge for developing CAR Ts for MDS. And so thus far, there are some targets that are being explored in clinical trials. And right now, there have been a very limited number of people with MDS that have been treated with CAR T.
Thank you, Dr. Silverman. Miles has heard from different sources that the amount and length of transfusions before starting luspatercept can reduce the effect of luspatercept. What is your experience?
So the experience has been that, and this is true in the sense that patients who are more heavily transfusion dependent do not respond as well to luspatercept as patients who have a lower transfusion burden. So in some of the studies, when we take patients and break them down into those with 4 or less units of red cells required transfusion-wise per month versus those with needing 5 or greater transfusions of red cells, 5 units per month, the patients with who are in the lower burden transfusion category, the 4 or less, have a better response than the higher transfusion burden. And that's not that surprising. In the data that I showed you about erythropoietin, same data were true, that patients who have a lower transfusion need and have less elevation of the red cell hormone in their blood are the ones that have a greater likelihood of responding. The others who have a high transfusion burden or a high red cell hormone have a much lower transfusion requirement. So stated another way, the greater the marrow failure, the less likely some of the treatments are to work. And the treatments tend to work better in patients with lower degrees of marrow failure.
Thank you. I have another question from Dr. Kareem. He has a young married patient who has MDS with multilineage dysplasia, who wants to now have a baby. She responded to thalidomide for the last 3 years with no need of transfusion. What is your suggestions for her?
That's a challenging question. So I've had some of my patients with low-risk disease, young women who've gotten pregnant, who've gotten through their pregnancy successfully. One of the questions that I would have for somebody or for the patient that you're describing is, what was the need for the thalidomide? Was it to support blood counts, to eliminate a need for red cell transfusion? Certainly, thalidomide can be used during the pregnancy period. There would have to be probably a substantial washout phase. And if somebody is transfusion burden dependent going into pregnancy from their MDS, then there's no data on the other types of therapies to support somebody through. So I would say that pregnancy in a patient like this would certainly be challenging, and may not be a realistic consideration.
Thank you. The next question is, I have heard studies involving use of antidepressant sertraline to improve low-risk MDS, but can't find results of these studies. Have any positive results been reported on this treatment?
No, there are a lot of novel therapies that have been used, and there are therapies that produce so-called responses in lower risk patients, and they they kind of get into the literature as small numbers of cases that are reported. This is the reason that it's so important to do these control trials, particularly where transfusion is the endpoint. So if you remember the slide I showed you about luspatercept, the response rate was in the around 38% with luspatercept, but the control group had a response rate of 13%, meaning that even patients who were just getting supportive care could have periods of transfusion independence that met response criteria. So MDS, because it is heterogeneous and individual patients can have varying behavior where transfusion need can wax and wane, the challenge is doing these randomized trials so we get a better sense of the true activity of the drug. So for this antidepressant drug, I'd say that there has certainly not been anything published in any kind of significant way, but you will find in the literature small numbers of patients treated with certain types of therapies that are said to produce responses that often don't pan out when taken into bigger trials. So green tea is one that comes to mind that's been advocated by some, curcumin another for MDS treatment, but none of those have been shown to really be effective in the general MDS population.
Thank you. The next question comes from Madeline. Her mother is 86 years old, has 5q minus deletion, and has been getting weekly transfusions for 6 months. They've tried Reblozyl, luspatercept, and before that Revlimid, but neither worked for a long time. Her quality of life seems better when she's not taking any medicines. At her age, quality of life may be more important than quantity of life. What is her life expectancy if we don't treat? What would the end be like?
Well, it's hard to say what life expectancy is because there are some pieces such as the percentage of blasts in the marrow that are missing and whether she might have any other mutations. So I agree the quality of life is one of the key factors, particularly for patients with lower risk disease. I would say that if she's gotten Revlimid or lenalidomide, and if she's gotten luspatercept and presumably erythropoietin or Aranesp, and she has not responded for a prolonged period of time, then just maintaining with transfusion support might be reasonable. And then one would have to consider chelation therapy for her, which could be done. And it can be done in pill form, and she should be able to tolerate it, and it would allow her to live longer lifespan with managing her transfusion requirement. The only other comment would be to see whether there might be some immune component. The T cells that I talked about briefly can play a role in exacerbating underlying low blood counts, and it serves as another target. And by attacking the immune system in some of these patients with T cell anomalies, we've lowered or reduced or eliminated the transfusion requirement for some patients. So this might be an alternative to consider for her as well.
Thank you, Dr. Silverman. We have time for just one more question. This patient was diagnosed with MDS 5 years ago at 50 years old and has been observed every year since. He stayed on the same blood work every year. Have you had anyone to not progress into very high and just stay in the low risk category?
So people can stay in the low risk or in a lower risk category for several years. The key is to make sure that nothing is changing in the marrow or the blood, so that they need to be monitored cautiously. But in that curve that I showed, people with a low, particularly very low risk disease can live with their disease for several years. And there were studies with somewhat younger patients in Europe done years ago showing that patients can live for 12 to 15 years in some instances with low-risk disease, and this were people in their 20s and 30s before needing a stem cell transplant. And so at 50, stem cell transplant would be a consideration, but it may not be necessary for a very long period of time. So close monitoring is really a key to making a determination of when the disease changes and how to change therapy appropriately to manage the change in the disease and see what types of therapy would be appropriate at that time.
Thank you, Dr. Silverman. Unfortunately, that's all the time that we have for questions. Thank you, Dr. Silverman, again for your wonderful presentation and your time and effort that went into preparing for this webinar. And thank you all for attending today and for your great questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with a link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.